Welcome. We thank you for joining us for our second video on the COVID-19 crisis. My name is Pastor Jill Henning, and I am the Assistant to the Bishop for Leadership and Administration for the Southeastern Synod of the Evangelical Lutheran Church in America. We are happy to provide this video as an educational opportunity for you to learn how to respond in the midst of this global crisis. And we are thankful that Dr. Erica Bjornstedt is joining us again to give us information and guidance and to help inform us of where we are as a nation at this point. So we are thankful to have Dr. Erica Bjornstedt. She is a pediatrician, an epidemiologist. She works in a hospital. She's a member of one of our Lutheran congregations in Alabama. And most importantly, she's a mom of a 4-year-old. And so we thank you, Dr. Bjornstedt, for being with us. And I'm going to let you take over now.
Thank you, Jill. Hello, everyone. As Jill mentioned, I am a pediatrician and an epidemiologist, but I also want to speak to you as a mother and Christian at an ELCA church in Birmingham, Alabama. I've also worked in low resource settings as a Peace Corps volunteer and in healthcare in Africa for the past 10 years. My goal with these talks are to continue to synthesize the large amount of information that is out there surrounding COVID-19 from the medical and public health perspective, and also provide guidance and tips on how to prepare for the next phases of this unfolding disaster. These videos are meant to be directed towards church and religious leaders, as well as lay leaders and others who are struggling to filter through the data that is out there. The ELCA will have a layperson video available in the coming days. I want to first and foremost make this clear that these are my opinions from what I have interpreted from the data that is out there. None of the institutions I am affiliated with are endorsing this talk. Things are changing daily and even hour by hour, so it's possible these slides will be outdated by the time you are watching this. The first video posted on March 14th is already out of date, but has some good background information you may find helpful. Third, I am not an infectious disease specialist. I am a kidney doctor for children. These are meant for educational purposes only. These are not meant to supersede the medical care of your local doctors or healthcare system. I tried to pull data from reliable sources as much as possible, the CDC or the WHO, or confirm at best as possible the articles, though I did not have sufficient time to vet it all. And some opinion articles do a great job of synthesizing the data as well. The data I'll present in this video is as up to date as possible for the afternoon of March 20th. These are the questions I will go through. My previous video covers earlier topics on the background of COVID-19, how to protect oneself, and how to tell this virus from the flu or allergies. Globally, countries all over are preparing. Stockpiling is becoming rampant in many parts. This is a worldwide pandemic, yet we are still in the quickly closing window of controlling it and slowing down its impact on our healthcare system and our society in the US. Other places are already feeling the strain. As I mentioned in the last video, we are soon to face life and death decisions that no doctor wants to be put in, that doctors in some parts of Africa and other low-income countries face on a daily basis. Instead of deciding whether or not you can save a life, deciding whether or not a person is likely to survive, and therefore determine in the greater good mentality who receives the scarce and precious hospital resources that are now in short supply. Ventilators that help people breathe. Hospital beds. Blood. What many of us once took for granted in this country, simple access to medical care, will soon be a limited resource. When there is insufficient capacity, those with life-threatening illnesses face dire consequences. China had to convert some hospitals to COVID-19 only hospitals to care for the massive numbers. Therefore, patients with other illnesses such as cancer were left in limbo on where to reach medical care. Some were left with the uncertainty, while at least one 19-year-old is reported to have died while awaiting access to medical care. Italian hospitals are making gut-wrenching decisions. Who is more likely to survive? Do some patients too old, too many other medical problems, need to be sent home to die, and make room for those more likely to survive? These are the questions facing doctors right now in Italy. In Milan, a fairgrounds has been converted into a 500-bed hospital as they are out of beds. Other places are using warehouses. Eye doctors, pathologists, dermatologists are being trained to manage ventilators. Age cutoffs are being used. I implore you to read this account of the situation from doctors on the front line in Italy. They are making life and death decisions that no doctor wants to make, and very few doctors in high-income countries have ever had to face. The Anesthesiology Society in Italy was criticized for coming up with ethical guidelines in those situations, but those guidelines are needed. Guidelines help frontline healthcare workers in their moral dilemma and can help prevent cherry picking or unconscious biases from creeping in. Washington State is now drafting and considering a similar triage document. Washington State is beginning to create COVID-only hospitals. We need to do more though. We need to learn quickly from what is unfolding in Italy. An Italian professor of virology, or the study of viruses, suggests we should have broader restrictions and tighter isolation controls now. Because social distancing and shelter in place can work. This is an updated version of the graph I showed in the previous video. It shows cases from once a country hit 100 cases. So how many days since they hit 100 cases is down here on the bottom. And then it graphs the total number of cases. And we are seeing social distancing and shelter in place effectively in action in South Korea and in Japan. Yet the US is here in pink, rising exponentially without signs of slowing down. We are on track to look just like Italy in the days and weeks to come. As of March 20th, the US now has over 15,000 cases. This number has doubled in only 2 days since Wednesday, March 18th. All states are affected. Darker colored states indicate those with more cases. And you can see that some states are being hit harder than others. It is yet to be seen if we will all face the same fate as Italy or if there will be hotspots in the United States. We also know the US has a very diverse population and diverse spread of resources. We know the Southeast has a disproportionate rate of heart disease, high blood pressure, diabetes, and kidney disease. Those are populations at highest risk for hospitalization and mortality with COVID-19. So will we see a disproportionate impact of COVID-19 in the Southeast as well? That is my fear. I hope I am wrong. Now I do need to walk you through some math. This is important because it is the best way to understand how fast this disease is spreading and why governments and organizations are quickly ordering more and more isolation measures, and why you should listen and do your part. This is the chart I showed in the first video, that if we don't slow things down and cases conservatively doubled every 7 days, we will be out of ICU beds by the end of May. Worst case at that time was we would double every 4 days and be out of ICU beds by the end of April. These assume the conservative estimate that only 10% require hospitalization and only 3% require an ICU bed. But we now have more US specific data. To remain consistent, I will only use total numbers presented from the CDC. And you can see that this week, we have seen a doubling of cases every 2 days. We also now know that 12% of infected patients are hospitalized in the US. So now, if things do not change and strict measures are not implemented nationwide, and we continue to double cases every 2 days, we will have 30,000 cases by Sunday, March 22nd, tomorrow. 2.6 million by Palm Sunday, April 5th. And by Easter, mid-April, we will have 10.7 million cases in the United States. By Easter, we could be out of ICU beds, and hospitals and doctors will be facing situations that my colleagues in Malawi and Zambia in Africa face on a regular basis. We will have to make life and death decisions like Italy within the next few weeks. We could learn from my colleagues in Africa right now. As of now, Malawi does not have a confirmed case, yet nationwide it is shutting down schools and universities as they implement social distancing widely, as they know what limited resources mean. The US does not. Some people out there still believe this is just like the flu and we don't need to worry. That is just wrong. COVID-19 is 10 times worse than the flu. Hospitalization rates for the flu are about 2%, while that of H1N1 are less than 1%. Yet for COVID-19, we have 12% infected requiring hospitalizations. Mortality is also 10 times higher. For the seasonal flu, it is about 0.3%, and estimates range from 1 to 4% for COVID-19. And remember, the seasonal flu runs its course over 8 to 9 months with an available vaccine. While we are seeing rates of infection rise with COVID-19 that could put us in these situations within weeks, and no one is immune. So no, it is nothing like the flu. Of the hospitalized patients with COVID-19, it is not just the elderly. 55% of those hospitalized in the US are aged 20 to 64. We continue to see that children are only making up 1% of our hospitalized cases, thankfully, but new evidence is emerging that they can still have just as severe disease as the elderly. We continue to learn as more epidemiological data is available. And as a reminder, epidemiology is the study of diseases in populations. It allows us to determine who is most at risk for infection in a population. If there are certain things such as age or diabetes that makes one more at risk. It is what determines that this particular coronavirus can infect a person one day. That person can have no symptoms and go about their daily lives, shopping, visiting a friend, for up to 2 weeks. And then on day 14, that person can develop a sore throat, day 15 a fever, and then be diagnosed with COVID-19. That person just spent 2 weeks before showing symptoms, unknowingly infecting many more people who might also go on to do the same. We have now learned that 20 to 40% of people may also be completely asymptomatic carriers. In addition to high blood pressure, diabetes, and heart disease, we also know that those with underlying kidney disease and those who smoke are at high risk for mortality. Also, the older population, particularly those older than age 50 or 60, yet we know that severe infection can still occur in people of all ages. Even though children for some reason seem less at risk for catching the disease, if they do catch it, they can have just as severe infections as the elderly. And it's particularly worse in babies less than 1 year of age. 1 in 10 infants infected may die. A newly published study indicates that 30% of patients with COVID-19 may have diarrhea, 10% may have vomiting. We had seen this earlier that this may be presenting signs in children, but we are also now seeing this in adults. More than 3/4 can have loss of appetite. This indicates that half of confirmed COVID-19 patients may have gut issues, as well as cough and congestion. There is concern that this may be why it has spread so fast in some communities and hospitals, as the gut symptoms sometimes come before the respiratory symptoms. There is a lot of rumors out there about certain drugs making you more likely to get infected. There has been no evidence or data to support that. Specifically, there is no evidence that a particular blood pressure medicine class known as ACE inhibitors is a risk factor. The WHO at one point this week suggested that ibuprofen may exacerbate COVID-19, but this has been quickly retracted as there was a misinterpretation of the publication. Until we have more data, there is no recommendation to change anything from what you were prescribed and told to do by your doctor before COVID-19 happened. So take your blood pressure medicines. What about a vaccine or drugs to treat COVID? The first vaccine trial began this week, yet we will be 1 to 2 years away before it makes it into routine availability. Drugs to shorten the duration and prevent death are also ongoing. Studies throughout the world are evaluating a variety of possible drugs. Because these drugs are already on the market for other diseases, it is possible they could be available faster. So far, there is none that has definitively shown itself to be effective. And at the earliest, we will likely not know something until the end of April or May. So now, in addition to keeping social distance and sheltering in place, what should we do when someone in our home is infected or has a fever? First, if you have symptoms or a fever, call your doctor. Do not, I repeat, do not just show up in clinics or emergency rooms unless it is a true emergency. You risk spreading it to many more people, and some may not survive. If you have symptoms, whether or not you are able to get the test to confirm it, stay home. CDC has these recommendations. Create a sick room. It will allow the germs to stay in one location that may allow you to prevent spreading it to family members. Limit as best as possible other people entering the room. Lots of hand washing, and consider wearing masks or scarves and gloves when doing so, or better, for the infected to wear so they don't spread it to the uninfected in the house. We do not yet know if certain pets or animals may be carriers or help spread it, so the CDC has recommended limiting contact with pets if you do have symptoms. Wear a mask if you must go out, and really should only be going out to go to the doctors. The mask protects other people from getting it. CDC has also now recommended that if a mother is infected, infants should be kept separate as much as possible. Consider formula feeding. It is not yet known whether breast milk can transmit the virus. And these are the emergency signs for when you need to call a doctor or go to the emergency room. Difficulty breathing, confusion, chest pain or pressure, or if someone is difficult or slow to wake up. Again, try to keep the room of the house as isolated as possible because the virus lives in droplets, the spit that comes out of your mouth, secretions from your nose and eyes, and the virus can live for up to 2 to 3 days at least on almost anything. So anything a sick person touches holds the potential to spread the disease for 2 to 3 days. And remember, people exposed and not yet showing symptoms can spread the disease too. And so what they touch can have the virus for 2 to 3 days as well. So when are you in the clear at home? First and foremost, talk with your doctor. The CDC states you need to have no fever for 3 days without medicines. All other symptoms must also be gone, and it must be at least 7 days since the symptoms first appeared. If you can get the test, it is a little sooner, but does require 2 negative tests. I want to reiterate this point. Yes, sheltering in place can work. Social distancing in some fashion is going to be required for likely the next year or more, most likely until we have an effective vaccine, but it can work. Again, this is the graph comparing countries since they reached greater than 100 cases. This is the graph as of March 12th. This is the graph as of March 18th. And I showed before how we are seeing Japan have a slow rise and South Korea is starting to mirror them. It is almost certain that countries will be hit differently and will have different stories unfold depending on the protection measures put in place and how quickly they are done. There are places that will look like St. Louis during the Spanish flu and others that will look like Philadelphia. The US is on track to look like Philadelphia if we do not act now. These are unprecedented times, and as such, they call for unprecedented measures. This week, the Peace Corps, for the first time since its creation in the 1960s, has suspended all activities and is evacuating all volunteers. The EU has banned all visitors for a month. This weekend, the US, Canadian, and Mexican borders will close to non-essential traffic. Italy and France have gone on a national lockdown. The Taj Mahal in India has shut down. The US Navy is lifting their strict hair length regulations to help slow the spread. 5 states have now issued shelter-in-place orders. Dentist offices around the country are only seeing emergencies, so brush your teeth and floss. Alabama's governor has issued a statewide no visitor policy for hospitals. The US tax filing deadline has been extended to mid-June. So how can we help as a body called to community, called to be with and help people in need? During the plague, Martin Luther encouraged folks to isolate unless absolutely necessary. Priests now are getting creative on how to maintain distance, yet provide comfort in this time of crisis. What if you don't have symptoms? Stay home. Call your local Red Cross for local blood drives. Hospitals in the US are running out of blood. Reach out to food pantries and shelters about getting groceries delivered to them, coordinating safe deliveries of grocery drop-offs. Help the elderly get their prescriptions. CVS and Walgreens in some places are offering delivery services. Pair up those bored teenagers with an elder member of your congregation to teach them technology. Loneliness is dangerous too. The recommendation is to isolate, but if you live by yourself and you have a friend who lives by themselves, consider making an isolation buddy pack together. This is going to be a marathon. We can only get through it together. Reach out to local disaster relief branches, especially here in the Southeast. I pray desperately that we have a calm and quiet hurricane season, but it is coming, and we may very well be in the midst of this pandemic still. If even one bad hurricane hits, it will be a perfect storm. Advocate for swifter and stronger action from your local leaders. And I agree with a former FDA commissioner who stated, if you must go out, wear a mask. You don't know if you have been exposed, and you could infect people for up to 2 weeks before you realize you are sick. The mask will protect other people. One person can make a difference. The first epidemiologist, John Snow, was in London when a cholera outbreak broke out in the 1500s. As hundreds fled the city, he calmly went into town, looked at the data, and determined that all the people who got their water from a single water pump were the ones getting sick. So he removed that pump, and that cholera outbreak stopped. So one person can make a difference and change the course of history for a few or even many. So I encourage you to think of your gifts and do your part. As a church, we are called into fellowship and community with one another. Continue to e-worship in doing so creatively. Zoom allows people to call in who don't have internet. FaceTime works from iPhone to iPhone. WhatsApp is a free app that any smartphone can download, so you can connect with video even if the other person does not have an iPhone. Prepare for funerals, weddings, baptisms to be done remotely. Consider only the smallest of gatherings, the household. Plan for this over at least the next 3 to 6 months. Consider recording pianists or organists playing hymns for when they may be sick or unable to play. Reach out to AA groups in your church to see if they need remote meeting assistance. Begin planning for virtual summer camp activities for youth. Consider organizing your quilting groups or anyone with a sewing machine into making face masks. Consider virtual ways to videotape, and they can teach the younger generation to sew as well. Continue creative outreach efforts, as they will be needed now more than ever. The church can take swifter action and save many lives, but we need to act today. Every day we wait, maybe thousands of lives. Cancel all in-person worship services. Prepare for when pastors, preachers, priests, and lay leaders will become ill or even worse, die. Our church can advocate stronger for swift action. We can even reach across the great Sunday divide and advocate in unison with our fellow Christians, whether Lutheran, Episcopalian, Baptist, Catholic, Methodist, or another denomination. We are all Christians, and we are stronger when we are united. We can raise our voices together and change the way history is told about the U.S. I implore our leaders to reach out to their peers in other faiths. We are all God's children, whether Christian, Jew, Muslim, or Hindu. If our faith leaders and lay leaders advocate and unite together for swifter and stronger action, many lives could be saved. Together, we will get through this. I pray the tide will turn. I pray this will be viewed as an overreactive stance in the days to come. But if the data is correct and these predictions of what are to come are correct, if these numbers keep skyrocketing and our hospitals feel the stretches Italy is facing, our society will be forever changed. This is a generation-defining event that is already much bigger than 9/11. This could spark the Great Second Depression. Many lives could be lost. Yet if we stand together now, today, as God's children, we can determine how this story is told in the history books. We must stay connected now more than ever, regardless of the outcome. So stay home, cancel all in-person worship, and stay connected. Peace be with you all.
Thank you, Erica, for your willingness to educate and to equip us all who are facing this crisis. Please continue to go to the Southeastern Synod's website for updates and worship resources at www.elca-ses.org or our social media sites. There are a lot of ways, as Erica said, that we can support each other during this crisis. If you're able to donate blood, check with your local blood banks to donate. Check on those vulnerable populations and others. Shelter at home to flatten the curve. Wash your hands. And if you so, make face masks that can be donated to vulnerable people and to others that are accepting those donations. We are the church together. And so if your congregation isn't able to worship virtually, please check the Southeastern Synod's website for a list of congregations providing virtual worship. Also, the Synod staff are recording sermons, and those are posted on the site in both a written form and a video form, and a Spanish video version will be available shortly. And know this, in the midst of a physically distancing society, God is not distant from us. So we can all pray for those infected, for our healthcare workers on the front lines, and for our elected leaders, and for each of us. So now let us pray. O God, where hearts are fearful and constricted, grant courage and hope. Where anxiety is infectious and widening, grant peace and reassurance. Where impossibilities close every door and window, grant imagination and resistance. Where distrust twists our thinking, grant healing and illumination. Where spirits are daunted and weakened, grant soaring wings and strengthening dreams. All these things we ask in the name of Jesus Christ, our Savior and Lord. Amen.
Amen.
Thank you, Dr. Bornstead, again for your time. And please check back at www.elca.ses.org for updates during the COVID-19 crisis.